Good afternoon. Everyone is welcome. Happy to have you here. This is our first meeting of the Subcommittee on Health for Appropriations. So welcome, everyone. Before we get started, we're going to have a word of prayer, if you would, Representative.
Good afternoon. I invite you to do what you do when you pray. Lord, thank you for all those who are present today. Thank you that we can come together as individuals with different gifts, ideas, and strengths to pursue a common goal. I ask that you fill each heart with your presence and grant each mind clarity. Please help us to use this time wisely, direct us in the way that we should go, and the path before us is clear. May all we do be to the glory of your name. In Jesus' name I pray. Amen.
Thank you very much. We're going to go ahead and we have some folks we're going to hear from today. We're anxious to hear things that are going on and some updates. And we do have a sign-up sheet. This is mostly agencies, but if you do want to sign up and have something to say, you're welcome to do that. Okay, first up, it's going to be our Department of Community Health. Commissioner Noggle, are you here? And we have a special treat, and we want to wish you a happy birthday. Please, we're happy to have you. We won't sing.
Thank you.
Thank you. We're happy to have you here today, and please bring us some wonderful information.
Absolutely. Good afternoon, committee, and thank you for the opportunity to be with you. Brian Lipton, our budget manager, is with me. He's going to advance slides for me, and I hope you all have a printed copy of slides as well. I'm going to start a couple of just high-level overview slides. I think you are mostly familiar with the department, but we're regulatory finance and compliance, so we're not actually out providing end services to our members, but we're the folks that are regulating. We're the big finance entity in terms of health agencies in the state and compliance. We've got about 650 staff, most of which are either in Atlanta, Cordele, and we have about 150 staff that are responsible for survey and compliance activities that are really remote because day to day they're out in our facilities. Just as a reminder, our FY23 base budget is $18.2 billion. That's total funds, 4.4 of that in state funds. I am going to walk you through line by line through your tracking sheet of our budget changes for the amended, and I'll stop when we get to the finish of that and take any questions you have, and then time permitting, happy to share some additional updates with you as well. So I'll start with Department Administration at 17.1.1. The department, there's a number of yes items, and so those are really just instructing the department to make some change or to do something either with existing funds or perhaps it won't cost any additional funds. The first is to submit a state plan amendment to CMS to expand express lane eligibility to include CAPS, refugee assistance, and WIC. That's a yes item. We expanded and were funded to expand express lane eligibility in the FY23 budget. And there was a significant investment in our budget to do that. Essentially, it aligns Medicaid eligibility determinations that when someone applies for Medicaid, we also check to see if they're eligible for SNAP or TANF or vice versa. And because of that, it speeds up their eligibility and the cost of those benefits for the increase or the sooner that we get them on, it costs a little bit more money. And so we have received CMS approval to do that. And so this is instruction for us to take that one step further and now add in these additional programs as well. So we will work on that pending that final language stays. 17.1.2, again, change any rules or policies necessary to provide inpatient psychiatric services to children under the age of 21 in our fee-for-service program. We are doing that, we believe, in large part. There are some different scenarios in which that's covered and not covered, but we're working through our policies to make sure we've got that identified, and we'll make any changes that we need to do to ensure that. 17.1.3 is an actual reduction of $6.5 million, and that's due to a disregard from the FY23 budget from the governor last session. 17.1.4 is a yes item, instructing us to pay for the routine physical exams and preventative care for all Medicaid members at our FQHCs and RHCs. We believe that is happening most of the time and in certain instances, but perhaps not in others. And so we're going to research that and make sure that we expand our policies to cover that. 17.1.5 is a long list of really DME or durable medical equipment, additional supplies and things that they want to see covered under Medicaid. Again, we believe that that is being covered in certain instances now, so we'll take a look at that gap analysis and see what we need to do to make sure it's available to all members and all programs. 17.1.6 is a transfer of $29.2 million in prior year state funds and 5.06 in prior year state general funds from other programs into this program. As part of the ARPA funding in our HCBS plan, we earned, I think it was about $190 million in federal funds, but we had to spend state dollars first. And so this is really an accounting and budgeting maneuver. We couldn't really reserve that money at the end of the year, but so this is a way to re-recognize it in the budget and get it into the right departments in order to effectuate that home and community-based spending plan with our federal funds. And so you'll see some of that movement a couple times, and that's just to get us in alignment so that we can spend that money now. At 17.6.1, the Indigent Care Trust Fund, it's a reduction of $9.7 million. This is really a true-up just due to this year's calculations. We had a hospital fall out of eligibility for some of these funds, which reallocated how the funds will be allocated under DISH, and it needed a little bit less state match to do it this year. In our Medicaid age-blinded disabled program at 17.7.1, there's an add of $79.5 million in Medicaid growth based on utilization. A lot of that is due to the high member numbers that we have right now due to the continuous enrollment requirement. 17.7.2 is $15.4 million, which is that enrollment growth because of the public health emergency. 17.7.3 on the other hand is a reduction of $276.7 million. This is actually a good thing because we have an additional FMAP enhancement, 6.2% right now from the federal government on our Medicaid expenses. That goes through March 30th, and then from April to the end of the fiscal year it starts to phase down. But this is essentially the state savings because of that enhanced federal cost sharing. 17.7.4 is a annual true-up item. 17.7.5 is a fund source swap. We're adding in our nursing home provider fees for our state general funds. 17.7.6, that Medicare clawback, $4.3 million. That's an annual true-up as well. 17.7.7, another yes item to true up those state general funds with hospital provider fees. 17.7.8, that 29.2 that we saw coming into admin is coming out and being reflected here in this program. $8.7 million at 17.7.9 in a new ambulance provider fee that was passed in the 2021 session and implemented this year. This is essentially a new provider fee for private 911 ambulance providers around the state. Well, they'll pay in a provider fee. With this $8.7 million, we'll be able to draw down an additional $20 million in federal funds, and all of that money will go back out the door to about $28.5 million in supplemental payments to, I think, 31 private ambulance providers around the state. And 17.7.1, again, recognize prior year state funds due to that increase in home and community-based services funding from ARPA funding last year. In low-income Medicaid, 17.8.1, $171.2 million to reflect enrollment growth and utilization. Again, a lot of that due to all the members that are currently still maintained on our eligibility rolls through June. 17.8.2, similarly, the savings from just like we saw in the other program, the increased federal cost sharing right now, $214 million in state savings, transferring those prior year state funds back into the Department of Administration, and then 17.8.4, $2 million in that hospital provider fee fund source swap with state general funds, again, as a yes item. Moving into the Peach Care program at 17.9.1, very similar items that we've seen reflect the enrollment growth that we're continuing to maintain at $11.7 million. During the public health emergency, 17.9.2, there has been a suspension of Peach Care premiums and copays for those families, and this $4.4 million will allow us to continue that suspension of those copays and premiums through the end of the fiscal year. And then again at 17.9.3, $14.7 million in savings due to the enhanced FMAP through the end of the fiscal year. In the state health benefit plan, there's $423.2 million being added in the amended budget, which is to increase the certified school employees per member per month rate from $945 to $1,580 effective January 1. Again, this portion is just for the certified school employees, and I believe there's a corresponding increase in the QBE DOE's funding to fund this on the other side. I've included on the next slide just that I shared this in our joint budget hearing, but our current SHBP financial status, actuals for the last 2 years, and what we're projecting for 23 and 24. Be happy to follow up with any of you offline or afterwards about some of these numbers. But we finished FY22 actually with a surplus of $72 million after we paid expenses from our revenue. And again, our revenue is just employee and employer premiums to the tune of $4.08 billion. Our expenses were just over $4 billion, so we had $72 million left that really goes to our operating reserve. However, in that revenue last year, there was $230 million in amended 22 one-time state appropriations, an additional $198 million that we received in COVID relief funds to pay for specific healthcare claims that were directly tied to COVID expenses. So without those funds, we would have certainly ended last year in the red. We are still projecting this is prior to any of the additional budget items that were added that the governor has recommended this year, but without those recommending deficits in both 23 and 24. And that's merely because expenses are outpacing revenues, and be happy to talk further with you or answer questions about that at the right time. In summary and amended, a total state funds adjustment of $230 million in savings, not including the add for the state health benefit plan, which is really accounted for separately. But I'll pause there. Happy to take any questions.
Yes, you have a question? Representative Chairman Hawkins?
Yeah, thank you. Hey, Kaylee.
Hey, sir.
I've been hearing a lot from the ambulance folks the last few years. You said 31 companies are going to be reimbursed. Out of how many? 31 out of
There
ballpark?
I think there was 80-ish, but there's only 31 that are deemed private 911 emergency.
Okay. So all the privates are going to
The
be?
privates.
Good. Thank you.
The privates, you're welcome. And we got some questions during public comment when we were implementing this provider fee and the supplemental payment program from some of the others of why they were not included. And in case you get those questions, it did not benefit them for us to do it. They would have ended up paying more into the provider fee than we would have been able to give back to them, which is based on their Medicaid utilization. And so we catered the program to be most beneficial to the most without causing others undue financial expense.
And I assume that the federal rule about you have to have losers. Okay, thanks.
Okay, let's see. Chairman Newton, do you have a question?
Yes, thank you for your presentation. Just on page 9 and 10, just was looking at the state health benefit. I did see the increase in the contribution per member per month for certified school employees. That's $423 million. But when we turn the page, it looks like we're currently a minus 716. Is there, are we making the 300 million up somewhere else? I know with the budget in the billions, these numbers are big, but there certainly can be some give and take.
So we still have a little bit of an operating reserve. So if you
Okay.
look at the end of FY22, the very bottom row is our reserve operating balance, not
Okay.
including OPEB. So even after we look at OPEB, we still have a few $100 million in the bank as our kind of fund balance operating reserve. So we'll draw from that, add it to that 423 if that passes in final budget, and fund our expenses there. At the same time, we're going to continue to look at plan design and other ways that we can shave up savings off of expenses so that we address both sides of both the revenue and the expenditure side. But we'll come back to, we're rerunning, projections with the governor's budget recommendation included, and can give you a better picture of what cash flow and these revenues and expenses will look like over the next 2 years.
Thank you.
I had similar questions. One of them I wanted to know, is there an increase in the number of employees in the state plan, or is it just utilization? I kind of wanted to see what the numbers look like, where the money's going, what kind of expenses. Did we have large claims?
I can tell you at a high level and then be happy to visit with you and bring you some detailed information as well. And in fact, we were just talking earlier, the Department of Audits and Accounts has done a really good financial and performance review that should be out literally any day that I think will answer a lot of questions. Our membership over the last 2 years is actually down 2%. Our expenses are really up, but our membership in terms of state employees is down. I can tell you, for instance, last year our inpatient facility expenses are up by about 20%. COVID hit the plan extremely hard. There were a lot of high-cost claimants that continue to drive those expenses. And generally, we're not a very healthy state population. And so what we want to try to do is tailor some of these plans in years going forward to really focus on making our members healthier to get some cost avoidance long-term. But we'd be happy to share some of the specific claims detail information with you.
Thank you, because one of my concerns is a lot of people I'm seeing had put off care that they should have gotten, and I'm afraid that's going to affect this coming year and next year, where treatment will be needed and it hadn't been taken care of because of COVID.
We
So,
share the same concern.
Thank you. Are there any other questions? Thank you very much. We appreciate it.
Thank you.
Okay, next up, we have, let's see, the Georgia Board of Health Care Workforce. Okay. Do you want the podium or at the table?
Be at the table.
Great.
Thank you.
If you would introduce yourself and tell us what you do.
Absolutely. Good afternoon. I'm glad to be here, and thank you for taking some time out to hear me out. Chet Basine, I'm the Executive Director at the Georgia Board for Healthcare Workforce. We are the state agency that is administratively attached to DCH. We do the data for the calculations of physicians, dentists, nurse practitioners that are throughout the state, from a county level, state level, and even from a specialty level. To give you an example, other things that we do are administer a public-private grant to two medical schools, Mercer and Morehouse. And then there's another program that we also administer called the Physicians for Rural Areas, but we do that for nurse practitioners, physician assistants, dentists, and of course physicians, where if the provider, one of the four licensures I just mentioned, work in a county that has a population of 50,000 or less, they can earn on an annual basis dollars for their loan repayments. So that's kind of at some of the higher level stuff we do. We also do some other graduate medical education, what you would probably know as medical residencies, capitation programs, and then there's a few specialties that get an enhanced capitation. So we administer all those dollars for the state. That's who we are. Our board, I probably should take a minute and let you know, we're about 15-member board, predominantly physicians. There's one physician assistant, one nurse practitioner, and one business person. He's just not clinical. He's a very smart guy, but he's one non-clinician is what I'm trying to make clear. From a budget perspective for 2023 amended, we had no changes, and I'm be glad to take any questions. At an overall roll-up, our agency, as I'm sure you all are aware, we are about $100 million, so we're quite a bit smaller than, say, DCH, but I'm glad to answer any questions that the group has.
Does anyone have any question? Okay, Chairman Stevens? No, I'm sorry, Chairman Hawkins?
Thank you. I don't see a fiscal note for the dental on here. We still have, what, 25 that we give out? Is it that many? Ain't that right? And the amount is, what, 25 per year for 3 years?
It's $25,000 for up to 4 years.
Up for 4 years, okay. All right, thanks.
I do have a question. I know you mentioned several of our larger medical schools and the residency programs that you have. Do you work with all residence programs in the state, or is it just certain ones?
We work with pretty much every medical residency program in the state.
Okay. Have you noticed a few new ones popping up?
Yes, we do. And what we do also is, of the ones who have made mention to us that they have intent to either add or expand medical residency, we keep a list. And actually, just for example, last week, I sent out a note to those we are aware of, can you please share us your plans for the next year or two? So we kind of keep the list running and ongoing.
Okay. Thank you.
Thank you.
And let's see. Chairman Newton, go right ahead.
Just curious if, I know you're stable for the rest of this fiscal year. Are the programs being fully subscribed? Are there people who are not having their third or fourth year renewed because of funding? I'm just kind of curious where we are on it, or are there slots out there if more people would go to rural areas or whatever, help them qualify, that we have budgeted monies we could assist?
That's a great question. We actually just last week went through this fiscal year's loan repayment candidates in all 4 categories. And in each one of the 4 categories, we had more applicants than we had dollars available.
So if you don't mind, so you had to say no to people, or did you drop everybody to 20,000 instead of 25, or what's your process?
No, we did have to say no to, depending on the licensure type we're talking about. So I'll say the advanced practice registered nurse, the APRN bucket, had a lot more applicants. I don't have the total amounts. I'm glad to get them for you and send them over to your office later this week. But there were a handful of applicants that we just weren't able to provide them any funds.
Thank you.
Are you doing anything in the recruitment side of it? Are you going and looking for students and residents to come to Georgia, or that's not part of what you do?
That we are not in, that is not our primary focus. What we try to do is make more aware of this program. So what we have changed, and I've only been with the agency about 7 months now, we are using our online tools more to advertise like what we do, how we do it, and how they can qualify for it.
Okay, I know there's such a need for physicians. I know every state is having the same problem. I come from a rural area where it's extremely difficult. So I feel like this is a key part of directing residency programs. If we can get them in those areas, I think it will help.
I agree.
Are there any other questions? Okay, thank you very much. We appreciate it.
Thank you.
Okay, next is our Department of Public Health, Commissioner Tomey. Do you want the podium or the table? Thank you. Welcome.
Good to see you again, Madam Chair
Thank you.
and committee members. I just want to acknowledge my staff who are here, and particularly Will Bell, who's our Chief Financial Officer. Unlike Commissioner Nago, I don't have a lot of new things to talk about today, but I did want to go over some of the background information that we gave at the joint hearing, because some of you may not have been there, and I think it's worth repeating some of the issues, particularly that are unique about public health. By the way, I'm Kathleen Toomey. I'm the Commissioner of Public Health, and my job is to address the issue that Commissioner Nago raised about Georgia's health, and we're here to try to improve the health of all Georgians throughout the state. Our department is unique in that it's a hybrid kind of structure. We have the state office that supervises 18 health districts, each run by a district health director, a physician who reports to me, but 159 boards of health, all independent, overseen by that physician health director who serves as their CEO. So it's an unusual structure, and I don't believe any other state has a structure quite like that. And we serve all of Georgia, nearly 11 million Georgians. Why don't we move on to the FY 2023, this year's budget, because I, again, wanted just to highlight some of the new funds that we got last year and how that has really helped us. As you've heard from so many of the department heads, workforce retention and recruitment has been such a challenge for us in public health as it has across all the state agencies. And so that additional $40.5 million, that $5,000 per person increase that came this year to every single employee, including all 4,000 Board of Health employees that aren't technically state employees but working with us as part of our team, really has made a difference. But in addition, public health uniquely got a $16.3 million increase, which was specifically targeted to bring up to market midpoint many of those individual workers who were particularly important during the pandemic, and that we wanted to ensure that we were able to retain and recruit as we move forward throughout post-pandemic. That includes nurses, that includes epidemiologists, that includes the environmental health team. And so that, again, was just, we're very grateful for that, and it has made a big difference. And we can actually see some measurable improvements in recruitment, definitely in recruitment, and we'll see with retention as well. I also wanted to acknowledge the $9.9 million that the governor put in and that you also supported to the ADAP program. Some of you may not be familiar with the ADAP program. It's the AIDS Drug Assistance Program that serves individuals with HIV who have no other access to these life-saving drugs, who are uninsured or underinsured. And we were very, very grateful for these funds, because not only were we able to expand the program as we're trying to grow the program and really make it more focused and efficient, but as Commissioner Noggle said several times, with the unwinding of Medicaid, individuals that may currently be on Medicaid will now not have insurance but have HIV infection, and we'll be trying to join our ADAP programs. And so we were very grateful to be able to be ready to accept those individuals and keep them and maintain them on care, which is so critical. The other issue that some of you may have talked to me about last year was that of single-dose therapy. We were the last state to be able to offer this, and we are grateful that we've been able to expand the formulary to include that. And lead inspectors, sorry, which we are in the process of hiring. So again, something that was much needed, and to address the change that we were able to finally make in reducing the lead level at which we could take intervention. There are some good news stories out of COVID, and one of those good news stories has been the partnerships that we built initially to address many of the COVID issues, but particularly around maternal and child health. And we had some strong partnerships with AU, and you supported an additional partnership of $1.3 million overall, 1.2 with AU to be able to follow prenatal patients who are high risk for poor outcomes in maternal health, as well as 2 additional pilot projects in rural areas to do special postpartum services for those individuals. And so those have already are in the process of being, those contracts are being implemented and will soon be underway. I also wanted to acknowledge the Sickle Cell Foundation. That contract as well is ready to go, and acknowledge that important work in rural Georgia. Looking at the appropriation by fund source, I think there's a couple of key points that to emphasize. One is half of our budget is federally funded, and that is not unique to Georgia, but it certainly adds some challenges to how we can work with some flexibility. And these funds that we're looking at on this pie chart do not include the COVID funds. These are just the current regular operating funds to address the programs, both here at the state office, but also at the districts. And so they include everything on the federal side, from WIC to TANF funds that we're working with DFACS to implement, to various CDC programs that we're getting for programmatic chronic disease prevention, HIV, other things, but also the MCH block grant. If you look on the state general fund, that's 45%, so not quite half of our budget is state funds. But half of those state funds go to the counties in grant and aid. And so I think that's, again, I think very important to address, because of the federal funds, most of that additionally goes to the county. So much of our budget is directed outward to service delivery. And I did want to talk very briefly about our COVID funding as well, because many of you had questions about that funding. And I want to emphasize, as much as I can, that this funding was really unlike the Corona Relief Fund. This is very unlike ARPA. We didn't have any flexibility in how we can use that fund. The majority of the funding, if not all of the funding, came from HHS, most of it from the Centers for Disease Control and Prevention, and had very specific expectations of how we could use those funds. So of the 1.9 billion, more than half of that, has been already awarded or is obligated, but we can only do certain activities with it. We can't do chronic disease prevention. We can't do some of the things that we wanted to do with it, such as work in schools to provide behavioral health interventions, because the funds are strictly prescribed as to how they could be used. We can use those funds to maintain a surge workforce, and which we are doing, as well as those individuals who can carry out ongoing COVID activities. But these COVID-specific staff, at one point, was 2,000 more people than it is now, and most of those have dropped off our rolls. And so we have 1,000 permanent state staff, but very few of those COVID-specific were brought on during that surge, during the height of the pandemic. But I did want to highlight 2 specific awards because they will provide some very, very important increased capacity for our state. One is the Strengthening Public Health Infrastructure, Workforce, and Data Systems. You probably read about it in the paper. It got a lot of play in the media. But within that framework, we will be able to implement an electronic health record. And it will provide the funds not only to build that electronic health record, but to provide staff for the districts and the state office to begin the implementation. And I want to point this out because we have 159 counties. Every single county has its own electronic health record, which means that every time any one of you ask me for data, which many of you do, how many services of whatever the health condition was did you provide statewide or in Bibb County, I have to get those data by hand and hand tally. It's not, we don't have a record that we can just download and get it by gender, get it by location, as most, virtually every hospital I know can do that. And so we will, for the first time, be able to not only look at the data more effectively, but I think be more accountable to you all as to how our funds are being spent for specific activities. And the other thing I wanted to point out is that we got some additional monies for lab capacity. Many of you may have seen, or if you haven't seen that, we would love to show you our public health laboratory, which is over on Claremont Road in DeKalb County. That laboratory was built during Zell Miller's administration. Governor Miller sent staff to cut the ribbon, and there's only been some improvements in that lab really after 9/11, and that's to give us the capacity to do some specific testing for anthrax and some of the bioterror agents. But otherwise, there has not been a great deal of investment in the laboratory since that BSL, the safety lab, was put in at that time. And so this will allow us to expand our technology, really meet the needs currently, but even more importantly, meet future needs for the laboratory, and do some improvements on the structure of the lab itself, which is badly needed. You may have, some of you were in the room when I talked about the fact that over Christmas we had a major lab, as did many places, pipes break, and all of our computers that send the lab values out to providers who send us specimens were disabled. I mean, they're actually ruined. We had to replace, and some of our testing equipment as well will have to be replaced. And I think that was, if we didn't need a reminder of how important this renovation is, that was certainly it. And so, to sum up, in summary, we are very grateful for the budget that the governor proposed last year and that you supported, plus the additional funds that you supported, and we have no new additions to our budget. So that's the end of the presentation, except for questions, which I welcome.
Okay, let's see, we have a question. Is that, Representative Hughley?
Thank you, Madam Chair, and thank you for the presentation. And let me say that all of us in Muskogee County are really thankful for your staff down there. They have been our heroes for the last few years. My question has to do with the unwinding of Medicaid. What impact is that going to have on public health, do you think?
Well, I think the main thing is that those individuals who were on Medicaid previously but won't qualify afterwards will somehow fall into our care, either as unreimbursed care or fall into other programs like our AIDS Drug Assistance Program, ADAP, or Ryan White, the Ryan White program. You know, we are grateful that you all supported the maternal expansion for Medicaid, and it's many of those women will become part of, we will be able to expand and improve our outreach and access, and are really working hard to ensure that we reach those individuals. It won't affect, in a sense, kind of our funding, but what it will affect is, for example, how many women may seek WIC services from us, because WIC provides food, not only milk, but, and we think about formula because of the shortage, but other formula up to age 5 for children and pregnant women and postpartum. So we have a lot of assets we can provide to individuals who may not lose their Medicaid eligibility, but who can be served in other ways. And so I think we may see an increased demand on some of our other women's health services and others, as well as immunizations or other services we may be providing, which will soon need to be provided at cost in some cases.
Can I ask another?
Sure.
My other question is, what do you see? I don't hear anything about our chronic diseases like stroke and hypertension. What are we doing now that we're coming out of COVID? Those conditions are still here. What are we doing with those?
At this point in time, we have and are continuing to provide longstanding programs that have been in place for a long number of years, including cancer state aid and a hypertension program, CORE, the program that funds the regional cancer coalitions, and some districts have very aggressive outreach for hypertension control, diabetes. We don't have a consistent program. We do have a chronic disease prevention program, again, it's CDC funded, and although much of the focus was redirected, even of those chronic disease staff, redirected towards COVID, particularly at the height of the pandemic, they are now back and working and serving in the health department. So we are renewing that, but I hope we will be seeing some improvements in those numbers as well. But as was pointed out earlier, many people either did not seek care or suspended care during the time of COVID, and we know that. And so it's even more important for us to be looking at outreach to identify those individuals, not only who may be at high risk for poor outcomes of pregnancy, but also may be at high risk for things like diabetes and other health conditions that we can help prevent. So we recognize that, and we'll be working to do that, but we don't have a specific plan for that. Right now, the target is going to be on our maternal and child health, which is really, of great needs, and we are working across all the health agencies.
Thank you, Madam Chair.
You're welcome. Thank you. You have a question now, Representative Buckner.
Thank you, Madam Chair. Thank you. I echo the great work that you've done, and being a former public health employee, I always admire the work that you do and the hurdles you have to go over. In the past, we've heard reports that epidemiology was kind of a department that we had difficulty keeping people staff there, having the amount of staff that we need. And in light of the pandemic, we know how critically important that department is. Can you give us kind of a epidemiology report of what, are we having staffing issues? Do we have what we need so that we can predict some of the health issues that we might have to face in the future?
No, I'm really pleased to say that we've been able, again, with your support and the increase in salaries we're able to provide, we are able to retain staff. And to me, the real challenge was not so much here at the state office, because we do have I have to say it's a house of cards, because it's a lot of different federal grants. So we have a diabetes epidemiologist, and we have another epidemiologist, all funded, or a hepatitis epidemiologist, all funded by individual federal grants. But we did not have that kind of epidemiologic capacity at the district. And now we are able, because we are able to raise their salaries, we not only have been able to recruit them, so there's more capacity at the district where you need that intensive investigation. What I'm really pleased to say that you probably don't remember, because so many people talk to you, but last year I talked to you about the Woodruff partnership that we had with Emory, the partnership funded by the Woodruff Foundation, where we brought on epidemiologists to be mentored by state epidemiology team, by Emory faculty, and by our district epidemiologists. We have been able to not only keep on attracting new fellows from this project, but retain them in the district, because our salaries were now competitive and match the salaries that they were getting from Emory. And that's big news. I mean, to have been able to roll those individuals who've done such a great job during COVID into, interestingly, we are now moving them into other areas like chronic diseases, like diabetes, like hypertension, like heart disease, where we know we have major issues but don't have good data to know exactly where we need to go to begin those interventions, like we do with as we have with our our maternal child health outcomes. And so that, to me, is evidence of how much not only your salary increase was able to we were able to, through you, to provide to our staff, but we were able to keep those fellows on and attract a new group of fellows, and provide that increased capacity out in the field where it was so desperately needed. That's a long answer to your question, but as an epidemiologist, I'm very excited about being able to do this.
Thank you.
Representative Sabal, you've got a question?
I do. Thank you. Dr. Tooby, thank you so much for your work over the past 2 years. I can't imagine the weight on your shoulders, and we're very blessed to have had you at the helm as we went through that pandemic. In the budget, I was looking for the budget for the Office of EMS and Trauma. Is that included in one of these other budget items?
Yeah, it's actually under, if you look in budget, 38.4, EMS trauma improvement, 38.4 includes EMS trauma injury prevention, so it's both federal and state dollars.
Okay. Thank you very much.
Yes, sir.
I have a couple questions, just a couple.
Chair.
And one of them, you've kind of talked a little bit about it, but y'all did so much with really so little during that pandemic. It was a struggle, and exemplary services were delivered and taken care of. And one of the things we did see was the need for this infrastructure and the data system. So I'm very glad you've been able to come up with a program that we will be able to do that. But will it be just the patients that are being treated in the health departments that will be reporting, or will hospitals report to the health department that they had so many patients of something, and you will get that data?
We get that already for notifiable diseases. And that system, likewise, thanks to the generosity of the General Assembly, and last year and the year prior, we gave us the resources to create a new system, which we are in the process of developing that RFP. We also have issued and awarded an RFP for our new immunization registry, which as you probably remember, had a tough time with millions of vaccines and
Yes,
other
everybody
things.
has to keep a little piece of paper in their wallet, and that was hard to keep up with.
Exactly.
So,
And
it-
I know that we will, in the process of, that's being awarded, so will be rolled out, so we're very pleased. So those are underway. What this would be is collecting the information about patients we see, say in the Muskogee Health Department. And so how many women are you seeing for various services, for breast and cervical cancer screening, for other services? And then from what counties are they coming from, and when are they due back? All these things that the hospitals can do and we haven't been able to do in a consistent way, because it will be consistent across 159 counties, which it's never been.
And I've observed that some health departments provide more services than others. I guess it depends on the size of the community. And I think that might be something we want to look at to see. Again, rural communities are very small. They don't have a lot of people, so you cannot provide a doctor there every day, and we understand that. But I think it'd be interesting to look at it, what services are. And one other thing that just, as we were talking about it, did the department have to use very many of the, quote, travel professionals, the travel nurses and things like that?
We did not. That
Okay.
was largely something that was
The
required
private sector got eaten alive with it, and
the cost of that was extraordinary to
right.
hospitals.
And it has slowed
particularly
down a
rural
little bit, but
hospitals.
I was hoping that you didn't have to use much of it.
No, we had some temps, but not, again, we got some additional support from the CDC Foundation and others, just for these COVID-specific interventions. And one of the good things to let you know is that we've been able to get permission to train our current public health nurses to do expanded roles to provide additional services. And that is really very good news, so that many of the counties that didn't have access to some basic services now do, because the roles can be expanded for our own public health nurses.
Thank you. I don't see any more questions. We do want to express our sincere appreciation to you and the department, and you've gotten us through quite a tough time. So thank you very much.
No, thank you so much.
Thank you.
Really good to see you again.
Thank you. All right, that is all the speakers that we had on the agenda, but we have several folks that want to speak. And if you would come forward. Tanya Anderson, are you here? Do you want to sit at the table? Fine. If you would introduce yourself and tell us who you're representing.
Yes, ma'am.
Oh.
Thank you, and good afternoon, Chairman Taylor and members of the committee. My name is Tanya Anderson, and I'm the Executive Director for Youth Villages Georgia. Youth Villages is a nonprofit organization across the nation, and we're serving in 23 states in the District of Columbia. We are a nonprofit, and the services that we provide are mental and behavioral health services and therapeutic services to children, families, and young adults. Here in Georgia, we do provide community-based services to children and their families in their homes, and we have a residential program in Douglasville that serves a lot of young children who are in significant need of mental health services due to safety concerns, instability in their homes, communities, and in their schools. Our residential program is known as the Inner Harbor Campus in Douglasville, Georgia. And our campus is licensed as a psychiatric residential treatment facility. And we have the capacity of 128 beds, so 128 children that we're able to serve on any given day. We do serve a lot of Georgia's most difficult and challenging youth in our program. And today I want to simply express our gratitude and our appreciation for the rate increases that were approved for psychiatric residential treatment facilities during the 2022 session. This approval was certainly in response to our growing needs to address workforce challenges, which you've heard some of that already from other state departments, and also the subsequent rise in overall cost to operate our programs in order to meet the growing mental and behavioral health needs of children and their families, and to do this in a way where we're still providing high quality services. While we are still awaiting the final approval of these new rates from CMS, in order for us to be able to negotiate contracts with Georgia Medicaid funding sources, we still are nonetheless grateful for the approvals from 2022 session. As the committee continues to consider ways to support mental health providers in the years to come, it will be helpful if there was an opportunity to review the potential to update cost reports that are required to be submitted by mental health providers throughout the state on an annual basis. And these are required by state licensing agencies as well as regulatory agencies. And we are hoping that these reports, if they are updated and reviewed, will allow there to be a better way to process and to review future opportunities for rate settings so that we can meet the growing cost of serving children, youth, and families. I, along with my colleagues, are more than willing to have further conversations and meetings to discuss this matter in the event that there are some opportunities for review. And of course, we can do this at a time that is most convenient for anyone on the committee. Again, we are grateful for your leadership. We are grateful for the rate approvals that occurred in the 2022 session. And I am here to answer any questions that you may have.
Does anyone have a question? Representative Butner?
Hi.
Good afternoon.
In regard to workforce, I know that there are a lot of standards and rules and regs that you have to adhere to when you have a residential program for people, particularly youth.
Yes.
It's my understanding that some of the staffing requirements for youth in a residential treatment facility are very high 24/7. Like, you have to have a lot of staff on hand 24 hours every day. But when they're sleeping at night, there might be a way to help with the workforce if we didn't have to have that same high ratio of child to caregiver. Is that something that would be helpful to you and still maintain the safety of the child that's in your care?
Great question, and I appreciate it. Absolutely, I think reviewing the staffing ratio, not just for direct care providers, but nursing and other professional staff would certainly be helpful as we're looking at a way to sustain the overall cost to serve young people in our programs. So staffing ratios, overall expenses, the qualifications of our staff, how we onboard staff in terms of training and background checks, those things would be helpful to also consider as we're looking at how to meet the ongoing gaps and challenges with workforce.
Thank you.
I have a couple questions.
Yes.
What are the age range that go to your treatment, either the residential or the regular treatment plan?
Thank you for your question. So for our residential, so the psychiatric residential treatment program, the age range is from 6 through the age of 21. And we do have several 6-year-olds that are currently on our campus in the Inner Harbor. And then the average age range is 13 to 17. So we see more of your adolescent girls and boys between the ages of 13 and 17, but certainly we do serve younger, and then those that are moving into young adults.
And do you include developmentally disabled, those that are developmental?
Yes, we do.
Okay, so they're all included in there. Thank you. You've got your hands full. You're pretty busy.
Thank you.
We appreciate that service. People in our state need to know that you're there, so I appreciate what you're doing. Thank you. I don't see any other questions.
Okay, thank you.
Next, we have Helen Sloat and Melody Trimble. Y'all want to come up to the table? If you, again, would introduce yourselves. Yeah, that's fine. Okay, if you would introduce yourself and please begin.
Yes, ma'am. Well, good afternoon, Madam Chairman and members of the subcommittee and staff. My name is Melody Trimble, and I have the pleasure of serving as the CEO of St. Francis Emory Healthcare in Columbus, Georgia. My facility is 376 beds. We are on 2 campuses. We have the main campus, and then we have our Bradley Center on a separate campus. And we have a very wide catchment area in the Muskogee County area. As you also likely to recall, we hold the state contract for the Department of Behavioral Health and Developmental Disabilities to provide crisis beds, which are typically found in the CSBS. St. Francis, we appreciate all the support we have had for our crisis stabilization unit. I want to say thank you for that. Today, I am here to speak to you about workforce issues, specifically addressing physician workforce issues and the needs in our state and our community. And today, as I listened, I was like, this is exactly what we're trying to solve at St. Francis. In July of 2022, we launched at our expense a brand new GME program, yes, in the middle of COVID, an internal medicine program, a residency program. We began our program and admitted in our first class this year 10 first-year residents and 5 second-year graduates. I did not come and request funds prior to initiating this program. I did not. We have since then met with our Governor's Office of Planning and Budget. We've met with delegation, members of the Appropriation Committee, as well as Chet Bastine at the Georgia Board of Healthcare Workforce staff to provide details of the programs that we have at St. Francis Emory Healthcare, how we expended and initiated our internal medicine GME program, and what we're planning for a launch in the future of our psychiatric GME program as well. I am, and my team is committed to growing our resources needed to create access for those who are in need of services such as internal medicine and psychiatric services. For the amended budget of 2023, I would ask that you consider the following. Within the Georgia Board of Healthcare Workforce, the Graduate Medical Education Program, the state funding, we would like for them to help us with the 15 internal medicine residency capitation payments. Currently, that would about $284,000 would be in that amended budget. Also, to let you know that we've spent just about $1 million of our own money to set up those programs, and we need help to continue to grow our internal medicine residency program and to launch fully our psychiatric program. We will need build out for learning centers and work centers for the psychiatric program, so it's a build out of about $380,000 to accomplish that. Also around the administrative work for both the internal medicine and psychiatric programs, we have a one-time ask of $375,000 for that. We also need the construction of a learning resource center to accommodate the growth of the internal medicine program, estimated just under $400,000. These spaces and needs will help advance the additional learnings we need to accommodate our residents, as well as continue to grow the program. We also need a workspace for our residents and sleep accommodations that we're required to have, and seeking funding for that in the amount of $425,000. I'm happy to answer any and all questions concerning the internal medicine residency program and the psychiatric program, and I thank you very much for your consideration in the requests that I've outlined, and for allowing me to speak today.
I don't see any questions, but I have a couple. How many psychiatric residents do you currently have?
We have none yet. We are
Okay.
in the planning phase. We hope to hear next month that our program has been approved, and it's a 4-year program that will have 7, so a total
Okay.
of 28 psychiatric residents, psychiatry residents.
Okay, and your internal medicine?
It will be a program of 10, 10, 10, 10, but
Okay.
currently I have 15, and in July we will have 10 additional, so we will be up to 25.
And have any of them completed the residency yet?
No, ma'am, I launched that program. This is their first year.
Okay,
So we have 10 first years and 5 second years who are currently in the program as we speak today.
great. I appreciate that. Are there any other questions?
Madam Chair.
Yes,
May I
please.
say something, please? Hi, I'm Helen Slade. I'm with Nelson Mullins, and together with my colleagues at Nelson Mullins, we have the privilege of working with St. Francis and the Bradley Center. I'd just like to add that 70% of the students that they have in their internal medicine program actually have Georgia connections and are very interested in staying in Georgia.
Great. And you know I'm looking for rural folks. So
Yes,
yeah, I think everybody is. So we do appreciate that and what you are doing. I know it's a major expense that you have stuck your neck out there. So we do appreciate that. Thank you very much. No other questions? I see Representative Cannon. Did you want to speak? Please come forward.
Hi, committee members. Just wanted to quickly bring to you, to your attention, because we're all working on maternal health opportunities to help our state. Today is Maternal Health Awareness Day. Healthy Mothers, Healthy Babies is here. They are across the street, chalking in Liberty Plaza. They're trying to get over here, but it doesn't look like they made it yet. But they wanted me to just share with you about their special project this past year. They've been working on it for 3 years, and they finally just got through with it. It is a Medicaid doula pilot program. So what they do is they partner with care management organizations, and they match people who are pregnant and on Medicaid with a doula. They have matched 175 of those women, and those clients self-pay that doula to be their emotional support person in labor, and then they can reimburse that doula up to $700. There are a few other states like Rhode Island that have done this, and they've actually added it into their state budget. And so the goal of their work this year is to provide us all as legislators with a one-pager and a white paper on the data and statistics that have come out of this. Overwhelmingly, it has been better pregnancy outcomes for mama and for baby. And if they have self-funded this for this year at, like I said, 175 clients at $700, which is about $122,000. It's $122,500. But they would be interested in working with any care management organization, rural or urban, whether that's a hospital or another system, to move forward.
Could you share with us quickly? Everybody may not understand what a doula actually does. I think that would be good.
Certainly. A doula is a certified birth worker who works with other providers. So they are not midwives, they do not catch babies, they do not prescribe medicine, but they do provide emotional and physical support. So that could look like either helping a mother when she is laboring and she is bending down. They can show those comfort measures and help to kind of do counter pressure with her, or they can teach their birth partner, like their husband, how to do that with them if they are deciding to labor at home and then have the baby in the hospital. Additionally, they work with the other care providers in the hospital during that mother-baby unit time. So say the nurse is going out and is going to prepare for them to get their epidural. The doula is in there and just able to sit with them, keep them calm, help them keep their breathing going. And they normally have a relationship that they have started while the person was pregnant, so that they know how to tell maybe if their eyes are glazing over. And then afterwards, once the baby is born, they do postpartum checkups, at least 1 or 2, for that first month, and help them transition back to other healthcare providers to make sure that they go to that 6-week appointment and that they have maybe breastfeeding support if the baby's not latching, helping them to understand in a more comfortable setting like their home or their community space what they really need for that healthy baby.
Of concern for me, I think, don't they usually work with them while they're pregnant to make sure they go to the doctors and take their vitamins? Is that part of what they do in the beginning?
Yes, ma'am. That's a part of those prenatal care services. But again, they do not prescribe anything.
Right,
They just try to help really be a liaison.
Okay. Anybody have any questions? Thank you. We look forward to having some information from you. Thank you.
Thank you.
Is there anyone else that would like to address the committee today? Are there any comments from the members? Okay, thank you very much. We are adjourned.